Hello, good evening everybody. I am Dr. Sharwak Ramlan, Assistant Professor in Department of Otorhinolaryngology and Head and Neck Surgery. And it is my pleasure to welcome you all for this virtual CME Head and Neck 2021, the webinar series, organized by the Department of Otorhinolaryngology and Head and Neck Surgery, along with Yen Onco Center from Yenapaya Medical College, Yenapaya deemed to be University, Mangalore. And we present the fourth talk of this series. Today we have with us as our guest speaker, Dr. Azeem Mohiuddin, who is the medical superintendent and professor in otorhinolaryngology and head and neck surgery, Sri Devraj Ars Medical College, Kolar, and he'll be speaking about management of salivary gland tumors. Moderating this webinar, we have with us Dr. Deepak Ranjan Naik, Professor, Department of Otorhinolaryngology and Head and Neck Surgery, KMC Manipal. Sir, we welcome you. Thank you, sir.
Okay, sir.
We also have Dr. Sheetal Rai, Associate Professor, Department of Otorhinolaryngology and Head and Neck Surgery, Yenapaya Medical College Hospital, Mangalore. May I now request Dr. Sheetal Rai to kindly introduce the speaker.
Thank you, Dr. Sharwak. Good afternoon, sir.
Good afternoon.
It is my esteemed pleasure to be introducing you to the participants. Sir, Dr. Azeem Mohiuddin is a medical superintendent of RL Jalapa Hospital and Research Center. Sir is Professor, Department of Otolaryngology and Head and Neck Surgery, Sri Devraj Ars Medical College, Tamaka, Kolar. Sir is an excellent teacher and a surgeon par excellence, and he has been, we have all learnt a lot from Sir, from his lectures to watching him operate. Sir has around 79 publications in national and international, with over 372 citations. He has won winner of the Gurumurthy Gold for best paper among teaching staff in state and South Zone Otolaryngology conferences. He has also won the Bharat Seva Ratan Gold Medal Award in July 2013 by JIPRA Foundation in Chennai. He has been a teaching faculty at various head and neck, otolaryngology and oncosurgery CMEs all over South India. He is also the convener of head and neck oncosurgery fellowship program and oral oncosurgery fellowship program at Sri Devraj Ars University, India. He has given several guest lectures and demonstration of surgeries in various institutions all over South India. He is also a member of editorial board of Annals of Clinical Otolaryngology and reviewer for several medical and surgical journals. His areas of interest include voice conservation surgery in advanced laryngeal cancers, pediatric airway surgeries, epigenetics in oral cancers, locally advanced thyroid malignancies and salivary gland malignancies, and compartment dissection in oral malignancies with infratemporal foci involvement. We are extremely happy to have you with us, sir. Welcome, and over to you now.
Thanks a lot, madam. I don't know whether I deserve all those nice words, but indeed, I would like to thank the organizers, Dr. Vijay Lakshmi and her team, the Vice Chancellor, and Dr. Mohiuddin Kuti sir, who has recently joined you. We miss him. And also another of our previous Pro-Chancellor, Marshal Ranjan sir, will be joining your super specialty hospital as CEO from 1st April. So we miss all of them, but it's always a nice feeling having come to Mangalore, a highly academic city. It's indeed a privilege and honor for me to be visiting here. And of course, the moderators for this session, Dr. Deepak Ranjan Naik sir has been a close friend and mentor since a long time. Good evening, sir. And so also Dr. Bhaskar Alva. Nice being with you. And since morning, I had an excellent time moderating cases in a CME just next door in KS Hegde Medical College. Of course, right from Vice Chancellor, right, Dr. Satish Bhandari sir, HOD Dr. Rajeshwari madam, all their faculty, Dr. Vadesh Bhatt, and right up to the PGs, everyone is close to me. It's everyone in KMC is close to me in ENT department and few in surgery department. It's indeed a honor for me to visit Mangalore, a highly academic city, I should say, rather a city of academics. Today, it's my pleasure to be speaking on management of salivary gland malignancies.
Can someone please confirm if the slides are up and visible? We are not seeing it.
Yes, ma'am.
Okay. Can we continue? Hello? Yeah. Okay. Okay. Whenever I see a salivary gland neoplasm, I thank God that I'm a surgeon and not a pathologist. The reason lies in front of you. There's a huge plethora of conditions, be it benign, malignant, and tumor-like conditions. Just to name a few, the commonest benign tumor being pleomorphic adenoma, followed by Warden's tumor, and a host of other tumors like myoepithelioma, basal cell adenoma, sebaceous adenoma, ductal papilloma, cyst adenoma, etc. And a big list of malignant tumors. The most common malignancy in major salivary glands being mucoepidermoid carcinoma. Again, we have high grade, low grade, followed by adenoid cystic carcinoma being three types. The starting from least aggressive to most aggressive, the tubular, cribiform, and solid varieties. The carcinoma ex pleomorphic adenoma, a highly malignant transformation of a benign tumor, and various other malignancies, the lower grade actinic cell carcinoma and high grade adenocarcinomas, squamous cell carcinoma, undifferentiated carcinoma, etc. To add to this list, we have a variety of non-epithelial tumors. The list is in front of you. And few tumor-like conditions like benign lymphoepithelial lesions, salivary gland cyst, which is common in old age as well as in acquired immunodeficiency syndrome, the necrotizing salometaplasia, Kimura's disease, inflammatory pseudotumors, sclerosing cell adenitis, etc. So each time I see a salivary neoplasm, I really thank God that I became a surgeon and not a pathologist. This has been borrowed from Dr. Jatensha's atlas. Most of the salivary gland tumors that we encounter are from parotid, and 80% of parotid tumors are benign. In submandibular gland, the benign to malignancy ratio is almost 50-50%, and in minor salivary glands, 60 to 80% of all tumors are malignant, the most common being adenoid cystic. This is the benign to malignancy ratio in various salivary glands. And in addition, we have minor salivary glands at various unconventional areas, be it in the palate, be it elsewhere in the mucosa like lip, etc. be it in the nasal cavity or even right down to the larynx. Oh, the black mark has moved. I'm sorry. So when it comes to diagnosis of salivary gland tumors, the first and foremost investigation, I would say, is a FNAC and more appropriately a guided FNAC under any imaging. A guided FNAC is likely to yield more yield and guide you to the more representative area of a tumor rather than a necrosed part. Frozen section is something I would advocate only for margins or in doubtful cases for selected cases. And yes, if it's a small tumor, you can do an excisional biopsy. The advantages of FNA, I'll not go in too much into detail, just to have a run through it. The sensitivity varies according to the evaluator, but on an average, it has 85 to 90% sensitivity, and it's quite specific also. It's easy to perform an OPD procedure. There is no risk of seeding, hardly any cost. It eliminates non-neoplastic lesions and definitely differentiates benign and malignant. Even if it can't show you what tumor or what malignancy it is, it definitely will tell you whether it's a benign tumor, malignant tumor, or a tumor of non-salivary origin like lymphoma or something like that. I told you, frozen section has limited role mainly for tumor margins. Excisional biopsy will be adequate for a small tumor, cystic tumor, benign lesions, and of course it confirms whatever you are thinking. It can detect a malignant focus and guide you whether to be more aggressive later on. And the tissue can be used if necessary in special cases for special tests, which I'll be coming to later on. Just a few photographs: pleomorphic adenoma, a mucoepidermoid carcinoma high grade, adenoid cystic, in this case it's a cribiform pattern, a metastatic squamous carcinoma, etc. Now, another important investigation, particularly in parotid and submandibular, will be ultrasound. It's easily available these days. It's non-invasive, does not irradiate, it's economical, guides the FNAC, very important, be it the primary tumor or be it lymph nodes in malignant tumors, it guides the FNA. It identifies areas of cystic degeneration and calcification. It identifies subclinical lymph nodes, if any. So it's a very accessible and useful investigation. In fact, I would suggest in a large tumor, an FNA should not be done without guidance because you may be hitting a non-representative or a necrosed area. Coming to other radiological imaging, the most common is CT scan, usually with contrast. It shows extent of lesion, the infiltration, if any, in malignancy cases to adjoining areas. As I said earlier, it guides FNAC, shows bone erosion. Bone windows are very easy to decipher by ENT surgeons or by general surgeons. It identifies inoperability. In other words, the extent into the skull base or into the cranial cavity and bone erosions. And of course, you can pick up deep lobe tumors more easily. And you can also differentiate deep lobe tumors from oropharyngeal tumors. The arrow mark shows a deep lobe tumor. I would like to point to this plane here. If you have a radiolucent plane medial to the tumor, it shows a deep lobe parotid tumor or a parapharyngeal tumor. I think I jumped. Yeah. If that radiolucent plane is not there, if this plane is not there, it's more likely to be oropharyngeal tumor. Coming to MRI, its sensitivity is almost the same as CT scan, But in soft tissue, MRI scores over CT scan because any soft tissue involvement will be better delineated. The areas of cystic degeneration or any fluid show up, they just stand out on T2 weighted images, and it shows nerve thickening in, if any, particularly with regard to facial nerve. It does, to some extent, differentiate neoplastic from inflammatory conditions. And it's preferred investigation in soft tissue as well as in intracranial extension. Again, the arrow mark is showing a deep lobe parotid tumor. PET scan has a limited role. One, to look for recurrence. Again, a caution here. When you look for recurrence, it should be at least 8 weeks after treatment of the primary tumor. And suppose there's a small primary and large lymph node, a PET scan can show you the primary so that you can plan the treatment, be it concurrent CTRT or be it split therapy where we do a upfront neck dissection followed by radiation for the primary. And of course, in lymphomas, a whole body PET is mandatory. And in metastatic disease, it's helpful to look for the primary tumor. So the special tests are rarely used, the most common being immunohistochemistry in special cases like spindle cell carcinoma or carcinolymphoma, etc. Then very limited role for cytophotometry, molecular and cytogenetic studies, and electron microscopy. So the immunohistochemistry, there are a series of markers, immunohistochemistry markers like ES100, actin, myosin, myoepithelial cell, cytokeratin, particularly for lymphomas and undifferentiated carcinoma, and to some extent melanomas, the salivary amylase, the carcinoembryonic antigen, and thyroglobulin in metastatic malignancies. Now, having gone through this list and the aids to diagnosis, I would like to specify one thing. Whatever investigations, whatever aids we use in diagnosis is not a substitute, it's a supplementary for clinical examination. The first step should be a proper clinical evaluation. And in salivary gland tumors, we have something called rule of Eighties. I have partly mentioned this in the earlier slides. 80% of parotid tumors involve the superficial lobe. 80% of parotid gland is superficial lobe. 80% of intraparotid lymph nodes are in superficial lobe, usually around 18 to 20. 80% of parotid tumors are benign. 80% of benign parotid tumors are pleomorphic adenomas. 80% of untreated pleomorphic adenomas remain benign. It's only 6 to 10% which undergo a malignant change into carcinoma, ex-pleomorphic adenoma. And 80% of minor salivary gland tumors are malignant. And 80% of parapharyngeal tumors are benign again. And almost 80% of pre-styloid parapharyngeal tumors turn out to be deep lobe parotid tumors. So this rule of 80, I think it will be helpful for the young consultants and PGs. Now, whenever we talk of salivary gland malignancies, we should remember the first line of treatment is surgery, surgery, and surgery alone. Except in systemic conditions like maybe lymphoma, where we go in for upfront chemotherapy. Otherwise, majority of the salivary gland tumors are treated by surgery. And benign tumors, there can't be any other treatment other than surgery. So when we talk of surgery, there are a few terminologies you need to know. In parotid, we have something called superficial perotidectomy. We all know facial nerve passes through the parotid gland and divides, thereby separating the superficial lobe and deep lobe. There is no anatomical demarcation except for the fasciovenous plane of Patty. So what we call superficial lobe may be dipping between the branches of facial nerve deeper and vice versa. And when we say total parotidectomy, it's total removal of parotid gland saving the facial nerve. When we remove anything beyond it, be it branches or complete facial nerve, or the muscles of mastication, or the mandible, or the mastoid process in skull base, external auditory canal, whatever extending, depending on extent of the tumor, it becomes radical parotidectomy. We have another terminology, adequate parotidectomy. What do we understand by this? Adequate is adequate resection, that is with adequate margins. It's no compromise on the surgery. So the rationale for this would be a small benign tumor, usually in the tail of the parotid, which can be resected without having too much of salivary collection or fistula under the skin flap. So the best suited tumor for adequate parotidectomy, I would say, is Warden's tumor or a parotid cyst. It does have a limited role for pleomorphic adenomas. Coming to Tnm staging, we are all familiar, I should say. Other than carcinoma in situ, a tumor less than 2 centimeters without any extra parenchymal extension would be T1. 2 to 4 centimeters in diameter without extra parenchymal extension would be T2. Any tumor more than 4 centimeters or with extra parenchymal extension would be T3. And T4A, a tumor invading skin, mandible, the external auditory canal, or the facial nerve, and still resectable, is T4A. An unresectable tumor which is involving the skull base, pterygoids, or encasing the carotid. Here, when I say carotid, it's the internal carotid, would be inoperable. We call it T4B. Just a word of caution here. We do have some of the T4Bs, so-called inoperable, which turn out to be operable. For example, extension into infratemporal fossa across the mandible or along the pterygoids, extension into the mastoid process where you can drill and do away with the mastoid tip, though it's T4B. So a few of the selected T4Bs are still operable. We are all familiar with the nodal staging, the present 8th edition of AJCC classification. The only difference with regard to earlier classification for nodal staging for squamous carcinoma is extranodal extension. Any extranodal extension straight makes the nodal staging N3B. The rest remains except in HPV-induced cancers. We are all familiar with the staging based on the TNM classification. Now the guidelines, how to go about treating salivary tumors. When it comes to parotid, I told surgery remains the first line of treatment. When I say surgery, it should be complete surgical resection. In parotid, I would put it extracapsular resection. Because even in a benign tumor like pleomorphic adenoma, we have something called pseudopods. If you leave them behind, the tumor tends to recur. And not only recur, the dissection will be much more difficult. A violated field is always difficult to dissect. And on resection, if it's a benign tumor, you only need to follow up. If it's a low-grade malignancy, be it mucoepidermoid, or that is low-grade mucoepidermoid, or low-grade adenocarcinoma, or an acinic cell tumor, you only need to follow up if your resection has been adequate. Suppose you have violated into the tumor, causing tumor spillage, or there is evidence of perineural invasion, you need to give radiotherapy post-operative. And if the tumor is adenoid cystic or any intermediate or high-grade malignancy, we always need to consider whether we need to give radiotherapy in the post-operative setting, unless it was a very small tumor. So these are the guidelines for T1 or T2 or for benign tumor. Whereas in a high-grade malignancy or in locally advanced tumor, which we call T3 or T4, if there is no palpable neck node or no neck nodes detected on ultrasound of the neck, a total parotidectomy should suffice as long as the tumor is not stuck to facial nerve. If it's clinically N+, that is node is present, a total parotidectomy with neck dissection is a must. Even if you suspect lymph node involvement, a micrometastasis, like it may be T3 or T4 tumor, where you are not palpating a lymph node, but definitely expect micrometastasis or occult metastasis. In those cases, you need to do an elective selective neck dissection. If there are nodes, proceed with a full neck dissection, that is modified radical. Otherwise, a selective, that is supraomohyoid, should suffice. Now, after this total parotidectomy, if the histopathology shows complete resection, no positive margin, or no adverse features like deep invasion, deep muscle invasion, or bony invasion, skin invasion, or perineural spread, if there are no such adverse features, you only need to follow. And in T3, T4, you need to give radiotherapy. In adenoid cystic, you have to give radiotherapy, as I said earlier. Whereas if adverse features like intermediate or high grade or perineural invasion or multiple lymph nodes, extra nodal spread from a lymph node, or lymphatic or vascular invasion are there, then adjuvant therapy plus or minus chemotherapy is a must. Coming to follow-up after having resected the tumor, if there is a locoregional recurrence and patient was not radiated earlier, you need to remove all the macroscopic tissue with a margin, that is surgery, and you can follow it up with radiotherapy. Of course, if it's unresectable, then the game changes. It becomes more of palliative systemic therapy in form of chemotherapy, or you'll have to give palliative radiotherapy. Now, if the patient has had radiotherapy already, again, if it's a resectable tumor, you should resect the tumor with adequate margins, and if possible, re-irradiation should be considered. If the tumor is unresectable, again, it becomes a palliative care only. Coming to parotidectomy, the largest salivary gland being parotid, and the one which gives thrill to a surgeon is parotid, thanks to the facial nerve. So when we talk of parotidectomy, it's more of an art than a surgery. It's a pleasure to watch and a pleasure to perform. And there's no fun in doing parotidectomy but for the facial nerve. These terminologies I have already told you. The only thing I need to add is, in deep lobe parotid tumors, the options are either a total parotidectomy if it's a big tumor, or a very big one going into mesenteric space or something like that, or high up in the parapharyngeal space. We may need to do a mandibulotomy for access and do a total parotidectomy. Yes, if it's a well circumscribed benign tumor of the deep lobe, you can dissect the facial nerve lower division, separate it from the tumor, and gently enucleate the deep lobe tumor without having to remove the superficial lobe at all. For recurrent tumors, people talk of retrograde facial nerve dissection. That is, suppose a person has undergone parotidectomy by a competent surgeon earlier, the facial nerve can be expected right under the skin, and it can be adherent. So if it's difficult to find the nerve in certain cases, you can consider retrograde dissection. You can identify the branch, usually the marginal mandibular, where it crosses the facial vessels in the neck, and follow it retrograde. I have already spoken about adequate parotidectomy. Coming to the next slide, this is the For parotidectomy, should be performed under general anesthesia with the patient supine and neck extended and turned to the opposite side. I used to use this incision earlier in what we call modified Blair incision in front of the tragus with a gentle curve going below the mastoid and coming along the neck crease. Depending on whether or not to dissect the neck, you can bring it down much lower. Now I have slightly modified this incision in selected cases. The vertical limb, I take it in onto the free border or little on the inner surface of tragal cartilage, extend till the incisura terminalis and hide that part of incision. It's not only hiding the scar. Once you start raising the skin on the perichondrium in this area, on the tragus, it will straight lead you to the Conley's pointer, which is called as tragal cartilage pointer, which is one of the landmark for facial nerve. So this is the incision I am using currently. There are a few more modifications to give better cosmosis. The hairline incision on the mastoid can be extended for parotidectomy, and wherever possible, minimize the incision. Nowadays, you can use the endoscope for releasing small tumors if they are retromandibular particularly. Just another case showing the present incision, how we use it. This is Jatensha's modification of Blair incision. The aids to surgery being bipolar electrocautery, this is a must because unipolar tends to spread the current in the tissues. You can have thermal damage. A magnification for the surgeon's eyes being loop or being operating microscope in selected areas, and a nerve monitor wherever you have it will be invaluable. Now, how to elevate the skin flap? It's in the parotid fascia, the fat up and fat down plane, which is just superficial to parotid fascia. We call it superficial musculo-aponeurotic system. And wherever possible, we should save the greater auricular nerve, because God forbid if the tumor is stuck to the facial nerve and you have to sacrifice a branch, this nerve can be used as a graft. It's within the surgical field, adequate thickness, a sensory nerve, so no motor deficit, and very easy to graft. Now, what are the landmarks to the facial nerve? As I told just a couple of minutes back, the tragal cartilage pointer, the inferior most point of the tragal cartilage, also called as Conley's pointer, John Conley's pointer. The nerve is usually 1 to 1.25 centimeters lower, that is caudal, and at a deeper plane. The other landmark being insertion of posterior belly of digastric into the digastric ridge of mastoid. The nerve is always superior to this landmark. The tympanomastoid sulcus, you can actually palpate it while operating. The nerve is usually 6 to 8 millimeters above the sulcus. Junction of cartilaginous and bony external auditory canal, the inferior most point. Again, the nerve is around 1.25 centimeters lower. And in difficult cases, I told you, you can identify the marginal mandibular nerve in the submandibular fascia where it crosses the facial vessels, and from there you can follow it retrograde. This photograph again I have borrowed from Dr. Jatensha's atlas. A schematic diagram, the mastoid tip, the styloid process, the posterior belly of digastric, and the facial nerve. We have a ligament here which we call stylomandibular ligament. The nerve is usually about it. Another question, commonly asked question for the students, for the PGs, why does a benign parotid tumor tend to raise the earlobe? The answer lies here, because the stylomandibular ligament is quite unyielding dense fascia. The tumor has to grow either below it or above it. So when it has come from above the ligament, it tends to grow above it, raising in the stylomandibular tunnel, thereby raising the earlobe. Now, we all know facial nerve divides in the parotid gland into two divisions. These are temporofacial and cervicofacial. And in turn, these two divisions further divide into temporal, zygomatic, buccal, can be upper buccal and lower buccal, marginal mandibular and cervical branches. Aesthetically, marginal mandibular is the most important nerve, and functionally, for good eye closure, zygomatico-temporal branches are the most important. And while dissecting, always it's better to dissect to identify the main trunk of facial nerve where it enters the parotid, where I have shown all the landmarks. Better to identify it and proceed in antegrade fashion, that is along the nerve anteriorly. So we follow a plane which we call fasciovenous plane of Patty. And always touch the tissue above the nerve with a hemostat and cut within the jaws of the hemostat to avoid pulling or avulsing the nerve. Constantly keep the nerve under vision if use magnification if required. And always release that part of the gland which is away from the tumor first, always known to unknown territory. If it's a tumor in the lower part of the gland, release the upper branches first. If it's in the upper part of the gland, release the lower branches first. So you know the depth or plane of the nerve, it will be easier. And always maintain hemostasis, preferably with bipolar cautery. And in case you hit a bladder, don't panic, don't grab the tissue. Always put pressure on it with a small swab, peanut swab. Identify the bladder and catch it. If you're not identifying, dissect the adjoining nerve, make space, and then catch it. Don't rush and put a hemostat. This is a small video. Can we play it? This is just a 5-minute video. Yeah, this is just a 5-minute video. You can see I've saved the greater auricular and I'm raising the skin flap in what we call superficial musculo-aponeurotic plane. And you can see me, you saw me working on the tragal perichondrium till the Conley pointer. I've saved the greater auricular. The anterior branches you need to cut and preserve the innervation to auricle. Always stretch the tissue, open it, and then divide. It's always preferable to start postero-inferiorly so that you can mobilize the sternomastoid right up to its tendon, then identify the posterior belly of digastric, like what I'm doing now. It's much deeper to the gland and below the gland. Once you do that, you will be close to the facial nerve. Here you can see the main trunk of facial nerve and the two divisions have been demonstrated. You'll have to work along the branches, not against them. Remember, devascularization, stretching, or accidental touch with a cautery are the most common causes for facial palsy. I don't think any surgeon will intentionally, rather accidentally go and cut the nerve through and through. Another issue is the retromandibular vein. Please remember the nerve is usually superficial to the vein. So avoid ligating the retromandibular vein during the start of the surgery. The entire field becomes congested and vascular. Always dissect at least the main divisions of the nerve and then only take the retromandibular vein if necessary. You can see the various branches now. The temporal, the zygomatic branch. What I am dissecting here is temporal, this zygomatic branch. The upper buccal, you can see a filament going here. You are seeing the buccal branch, the marginal mandibular, cervical branch I have cut in this. Okay. Yeah, we'll come to slideshow. So a better still photograph of superficial parotidectomy being done. You can see the facial nerve dividing into lower division, cervicofacial, and the temporofacial division here. You can see the innervation to auricle is preserved in this case. The nerve almost completely dissected here. The temporal, the zygomatic branch, buccal branch, marginal mandibular. Another case. And this patient, the dissection of facial nerve is almost complete and the tumor has been removed. The last you take should be the Stenson's Dept after having rolled the gland anteriorly, saving all the branches. You can see all the branches here. The resected tumor and the post-op photograph. Earlier I used to put a Penrose drain. Now I always use a suction drain and anchor it through a skin stitch away from the nerve so that it doesn't go and irritate the nerve. So for deep lobe parotid tumors, I told you earlier, the choice is either to do a superficial parotidectomy, identify the nerve, rather dissect the nerve completely, mobilize one of the branches gently, usually the buccal branch, and deliver the deep lobe tumor between the branches. And if the deep lobe tumor is big, extensive into the mesenteric space or high up in the parapharyngeal space, you may need to do a mandibulotomy in addition to access the tumor. And very rarely, I would not advise this, very rarely in extensive and malignant tumors, you may have to sacrifice the lower buccal branch or something. I would not advise this. As far as possible, preserve every branch. If the tumor is stuck to any branch, you cannot separate it, instead of leaving a microscopic tumor behind, you can sacrifice dead branch and immediately graft it on table. And whenever the tumor is stuck to the facial nerve, you need to give adjuvant treatment also in form of radiotherapy. A deep lobe parotid tumor pushing the tonsil medially. Closure. Another patient. A deep lobe parotid tumor. This was a deep lobe parotid tumor. You can see the dissected facial nerve. I have done a superficial parotidectomy here, and the tumor is lying deep to the facial nerve. So this I could deliver by, this was going high up as well. I had to do a mandibulotomy, and you are seeing the deep lobe tumor here with an easy access. That's the dissected facial nerve here. So after a mandibulotomy, it came out easily. This is after resection. This is the dead space after having resected the tumor, and you are seeing the lower division of facial nerve here, the resected tumor. This was a slightly extensive tumor where the tumor had infiltrated into the ear canal, into the external auditory canal. She presented to us with a discharging ear. On examination, there was a mass in the external auditory canal, and the biopsy showed a malignant salivary gland tumor. It turned out to be adenocarcinoma high grade. It had eroded through the cartilaginous portion of external auditory canal, which is not a very common feature because cartilage, rather the perichondrium, is quite resistant to tumor spread. So in this case, I had to drop the vertical incision in front of the tragus. I couldn't go behind because the cartilage was eroded. I had to sacrifice it. The facial nerve having been dissected, and so also part of the cartilaginous portion of external auditory canal, what we call sleeve resection. This is the remnant there. This is the bony cartilaginous junction here. I had to do a sleeve resection in this case, along with a neck dissection. You can see after complete resection. Now, what are the things to remember for my younger colleagues during parotidectomy? Always follow a correct plane of dissection. The plane being superficial musculo-aponeurotic system for raising the skin flap, and the fasciovenous pattis plane for nerve dissection. Remember the landmarks. Maintain hemostasis with a bipolar cautery. Keep the nerve under constant vision. Gentle handling. Never stretch the nerve. Never devascularize the nerve. And use the surgical aids like bipolar cautery, magnification, etc., and nerve monitor wherever required. And whenever you are doing a superficial parotidectomy, particularly for pleomorphic adenoma, complete resection of superficial lobe is preferable. Otherwise, you will have remnant tissue keeping on oozing saliva. You will have to keep on draining it frequently. And suction drain to be placed away from the main trunk of the nerve. Now, coming to soft tissue reconstruction, you may have a big hollow after removal of a big tumor. You can use temporalis muscle, or the upper third of sternomastoid can be rotated there to fill up the gap. And wherever you have had to resect the bone, that is mandible, or you have had to resect the skin, there are various axial as well as microvascular free flaps at your disposal. The workhorse being pectoralis major myocutaneous flap if it's a bulky area, a deep hollow, or if it's only skin reconstruction, you can use deltopectoral flap, or you can consider microvascular free tissue transfer. Now, what are the indications for neck dissection in salivary gland, rather in parotid malignancies? 1, the high-grade tumors. 2, when you have aggressive malignant behavior like perineural invasion or deep muscle invasion like masseter, etc. When you have either extranodal spread or multiple lymph nodes, and all the locally advanced T3 and T4A tumors. Similarly, the indications for post-operative radiotherapy. We have high-grade malignancies, involvement of skin, mandible, muscles of mastication, etc., or even the mastoid tip. The lymph node metastasis, particularly multiple nodes or extranodal spread, perineural spread, or when your margins, resection margins are close, and surgery for recurrent malignant tumors, you need to follow up with radiotherapy. Now, when do you sacrifice a facial nerve or a branch of a facial nerve? When there's a pre-existing facial palsy with the nerve stuck to the tumor, or when there is fixity of tumor to the nerve, you cannot separate, there you have to sacrifice that branch. When the tumor has gone beyond the nerve, deep to the nerve, be it masseter or mandible, that branch overlying the tumor, if it's not moving freely, needs to be sacrificed. And encasement of the nerve by a malignant tumor, there's no question of saving it. You need to cut it and graft it on table. The grafts, most common one being greater auricular, and a long segment can be grafted by a sural nerve, or I have even used anterior rami of cervical plexus for grafting, particularly the upper divisions. Now, in long-standing facial palsy, facial hypoglossal anastomosis is an option. Facial and nerve to masseter can be an option, or static procedures like temporalis sling or facelifts to improve the appearance, and of course a lateral torsorrhaphy whenever there's a facial palsy to protect the eye. Now coming to submandibular tumors briefly. As I said earlier, 50% of these turn out to be malignant. The treatment is excision of the gland with a rim of normal tissue. And for malignancies, you need to do a neck dissection. And wherever the tumor is locally advanced or aggressive, or when it's associated with closed margins or adverse features, you may need to give post-operative radiotherapy. Where the tumor is stuck to the marginal, either a reverse marginal mandibulectomy if it's only stuck to periosteum, or if it's infiltrating, a segmental mandibulectomy will have to be done along with a neck dissection. You can see a large submandibular tumor. It was resected. Structures of importance while doing submandibular gland dissection: the marginal mandibular nerve, which lies in the submandibular fascia, crossing superficially to the facial artery and vein, and soon after crossing it turns upwards. It runs parallel to the mandible till it crosses the facial vessels. The facial artery, it enters the gland deep to the posterior belly of digastric, almost bisecting the muscle, and in the gland it gives the submental branch and then leaves the gland close to the mandible. The common facial vein is another important structure. Lingual nerve, usually it's attached to the submandibular gland at the submandibular ganglion. You need to dissect it deep to the mylohyoid and you can follow it. The moment you release the submandibular gland, it will move safely away from the tumor. Hypoglossal nerve, it runs parallel and just above the digastric muscle, rather deep and just higher than the digastric muscle. If you follow the digastric, there's no chance of missing hypoglossal nerve. And anteriorly, the structures from above, below, from top to lower, you have the lingual nerve, the Wharton's duct, and hypoglossal nerve. A submandibular gland dissection, you can see the digastric, posterior and anterior belly, the tendon. This is the mylohyoid, and this being the lingual nerve, and the hypoglossal nerve is here. The facial artery has been, this is the facial artery. The tumor is only hanging on facial artery and it has been delivered anterior. The marginal mandibular nerve in this case, you can see it here running high above the gland in the submandibular fascia, the ligated facial vessels here. Another, along with neck dissection, the submandibular tumor has been removed along with the lower part of parotid in this case. Neck dissection in progress. A completely dissected neck. Now a few words about minor salivary gland tumors. As I said earlier, 80% of them turn out to be malignant. The most common minor salivary gland tumor is adenoid cystic. That's why it's usually seen in palate. The other areas being nose, paranasal sinuses, any part of the pharynx and larynx, sometimes even a peritonsillar space where we call gland of Weber. And the same applies for any salivary gland tumor, surgery followed by adjuvant treatment, usually post-operative radiotherapy. And when we say surgery for a malignancy, you need to have adequate margins. With this, I would like to thank the organizers for having called me and the delegates and audience for their patience. If there are any questions from your side, it will be my pleasure to discuss with you. Thank you.
So there are a few questions
Sure.
for you.
Yes, ma'am.
One question is, what is the role of neutron therapy in salivary gland tumor?
Neutron therapy in selected salivary gland tumors has a role, but the issue is it's not available in most places. I think only 2 or 3 centers in the country are having the neutron therapy. And so also there are a few non-salivary origin tumors where it has been used. A few sarcomas also where it has been used.
The next question is, in parotid tumor with 7th nerve involvement, do we resect the facial nerve, and how to decide the margin of nerve resection?
As I said, wherever the tumor is stuck to the parotid, stuck to the facial nerve, if you cannot separate, that means it's infiltrating the nerve. So you need to resect that, and how much to resect? You need to have at least 1 centimeter margin from the point of attachment. And I would suggest a frozen section of the nerve to see if the resected segment is free. And wherever you cut the nerve, use a razor sharp blade or a real sharp scissors to cut it. Don't crush the nerve. And on table, it should be grafted, and such a patient should go in for adjuvant treatment. And if there is pre-existing facial palsy with the tumor stuck to it, there's no question of saving the nerve. A word of caution here, you may have a big tumor causing pressure on the facial palsy without actually being stuck to it. There, save the nerve, give an adjuvant treatment, and you will see once the tumor is out, the palsy recovers in a couple of months.
The next question is, how to avoid or manage post-operative salivary leak?
The post-operative salivary leak occurs when you leave significant parotid tissue behind. Even if you have left the full deep lobe for a benign tumor, a pleomorphic adenoma, you have done superficial parotidectomy. Even if you leave the full deep lobe, after a period of time, it does undergo some atrophy. The salivary leak stops. The only suggestion I would give is minimize undue trauma to the remnant parotid tissue. Don't don't leave crushed tissues. Have proper plane while raising the skin flap. Otherwise, you can end up with French syndrome. And wherever possible, I showed during my slides, remove the entire superficial lobe. If you leave significant tissue, you are likely to have a leak. And if it's a malignant tumor where you have got a margin without resecting the full deep lobe, even if there's a leak, once you radiate, it will stop. Otherwise, there are other options like octreotide, a somatostatin analog, to try and bring down the secretion.
If the buccal branch is severed,
yeah,
how will you reconstruct it? Or what
any
will you
branch,
use for grafting? Yeah.
Any branch, the choice of grafting, unless you have metastatic nodes or primary tumor there, I would suggest greater auricular because it's within the field. If the tumor was extending there, you can always use the sural nerve.
What are the indications for facelift incision in parotid surgery?
Depends on how appearance or beauty conscious your patient is. I would suggest all these facelift approaches only when you have adequate experience with conventional approach, because in the process of trying to avoid that small segment of scar, you should not end up with a facial palsy or maybe leaving the tumor behind. That will be a disaster.
So there are 2 more questions.
Yes.
One is how to avoid Frey syndrome as a complication. And the other thing is how to treat salivary fistula which persists even after 1 month of tight bandage. Dr. Vadish has joined us. He's asking how to manage a post-operative silocele after superficial parotidectomy.
Silocele, I would suggest if your remnant of parotid tissue is minimal, just do a aspiration under the skin for a couple of sittings, and usually it will settle down as healing occurs. But suppose it has been a cut laceration, an assault case, having caused a salivary fistula. If it's not settling down, you need to go in and do a superficial parotidectomy at least. And there are, I told you, somatostatin analog, octreotide can bring down secretion till the healing occurs. If you have a problem for a benign tumor, if you have done an enucleation, then I think the superficial lobe needs to come out. You need to go in again.
So how long can we give octreotide for a salivary fistula?
Actually, if you ask me, not more than 2 or 3 weeks. It's a costly drug, and if it's not healing in the time required for healing, it's unlikely to heal. It has formed a fistula. It's no longer a leak. So there you may have to go in again and resect the superficial lobe at least.
There's one more question, sir. What is the surgical treatment for isolated deep lobe of parotid tumor?
As I was telling during my slides, if it's a malignancy, you need to have adequate resection, you need to have approach. So the best option would be a total parotidectomy. You can do a superficial parotidectomy, identify and dissect the nerve, and deliver the tumor either below or between the branches of facial nerve. Suppose it's an isolated, small, well circumscribed tumor of the deep lobe. You can dissect the main trunk and the lower division of the facial nerve without actually disturbing the upper division, and with a margin you can gently enucleate the deep lobe alone without having to resect the upper, the superficial lobe at all. And sorry, I forgot, there was a question on how to avoid Frei's syndrome. Frei's syndrome occurs usually when your skin flap elevation is too superficial. When you have cut through the auriculotemporal branches, faulty reinnervation occurs, and the impulses the fibers supposed to go for salivary gland end up in the sweat glands. So for this, have an adequate thickness of flap elevation. You should elevate just above the parotid fascia, the superficial musculoaponeurotic system, what we call fat up, fat down plane. If your flap is not thin, the chances of Frei's syndrome are minimal. Suppose you think the flap is thin, the tumor was coming subcutaneous or something like that. There, try to interpose some tissue during closure, maybe a sternomastoid rotation or temporalis rotation. When there is tissue intervening in between, Frei's syndrome is unlikely to happen. And when it has happened, you can give topical pilocarpine, you can give octreotide, you can resort to tympanic neurectomy, etc.
Thank you very much, sir.
Thank you.
Dr. Deepak Ranjan Naik, Professor of ENT from KMC Manipal, is with us as moderator.
It's a pleasure.
Thank you very much, sir, for joining us.
Thank you,
Request you to give your remarks, sir.
The excellent talk.
Thank
Has
you,
covered all aspects.
Thank you, sir.
And just one question I wanted to ask.
Yes, sir.
How often you do for the external auditory canal extension, do superficial temporal resection?
Actually, it depends on extent of the involvement, sir. Like
bony external auditory canal.
what video what photograph I showed you, I told it was an erosion in the cartilage, which is quite rare.
Yeah.
I would expect a tumor coming between the cartilage and bone. I would expect a tumor eroding the bone.
Yeah.
If the periosteum is disturbed. Here it had eroded through the cartilage. So
Cartilage, yeah. This is a sleeve resection, yeah.
So if it's only in the outer part of external auditory canal, a sleeve resection should suffice. Whereas if it's going deep, eroding the bone, you should do a mastodectomy and maybe a temporal bone resection. But if it's into middle ear, I think it's not a tumor to be operated.
And any role of botulinum toxin, particularly Frei's syndrome?
Yeah, for Frei's syndrome, that's an option, sir. Very much an option.
There's one more question, sir. Yes. Any role of hyoscine patch for the salivary leak?
Yeah, you can do that. It's only thing, it will be like using a country-made pistol against a enemy tank or something like that. It will not suffice.
I request all of you to kindly fill the feedback link which is given to get your e-certificate in your email. Thank you all. Thank you, sir, the moderators, and all the participants.
Thank you.
Thank you.
Thank you, Madam Vijay Lakshmi. Thank you, Gangadhar sir. And thank you, Deepak Ranjan sir. Nice.
Thank you. Thank you, Dr. Gangadhar, and thank you, Dr. Azeem.
Thank you. It was a pleasure being here. In fact, today has been a very nice day in my life because whole day I was in case Hegde moderating cases for my younger colleagues, and now I am here. And now I can go back and meet few of my mentors, or at least ring them up. There are so many in Mangalore. As I said, coming to Mangalore is sort of something I always look forward to, because I've been coming since a long time. Almost once or twice a year has become a routine for me, and I enjoy coming to this city of academics. Thank you, sir.
Thank you all. I hope to see you all next week for our next talk on the next week for our next talk on head and neck. Next week it will be at 2 o'clock, 2 to 4. Thank you, everyone.
Thank you.
Thank you.